Dear friends, dear colleagues, it's a pleasure to be again at UROONCO in Seville today with my dear friend, Dr. Bas van Rhijn. Thank you, Bas, for being with us.
Okay.
So you are working in Amsterdam at the Cancer Center. You are part of the EAU guidelines, and you work a lot on NMIBC and upper tract. Today in Seville, you have presented a very good lecture, state-of-the-art, regarding TEP, FDG, in upper tract urothelial carcinoma.
Yes.
We know that, especially in Netherlands, there were early adopters of the use of PET for urothelial carcinoma. Can you give us a bit a brief rationale for the use of PET FDG, not in bladder cancer, but in upper tract first?
Upper tract. Okay. Well, Benjamin, thank you for having me. Indeed, I'm Bas van Rhijn, working in Amsterdam in Netherlands Cancer Institute as of 2011. And when I started working there, we actually introduced the PET in our hospital. And I must say that we have been, indeed, early adopters of it. And not only bladder cancer, because our bladder cancer clinic harbors actually also upper tract urothelial carcinoma. So we have also done substantial amount of upper tract cases. And I'll show you a case in the presentation. However, what do we know about FDG PET in upper tract? Well, first of all, staging bladder cancer kind of has two components. First of all, you have the T stage, and you have also the N for the nodes and the M for metastasis. Well, the PET scans are especially efficient in the nodal and also in the distant metastatic state.
This is something that we know from bladder cancer.
Yes, but also for upper tract cancer as well.
Okay.
And we have actually, there is only one study that is with a reasonable amount of cases, 152, and that was a multi-center study done from centers across the whole world, and actually kind of coordinated from Amsterdam. One of our PhD students published a study, and after taking out the cases that had neoadjuvant treatment, we were left with 117 cases, and we looked at PET positive and PET negative patients that were all M0 on initial staging, and they were all kind of considered high risk, UTUCs. And then we clearly found that if you are PET positive, then in the nodes, then you have worse survival compared to the PET negative ones. So that is for the 117. And then there were, after, of course, I already said the exclusion of the neoadjuvant chemotherapy, there were 62 pairs of a nephroureterectomy and a lymphadenectomy. And there we found that the accuracy of the PET-CT to predict nodal metastasis is around 84%,
okay,
which is higher than you would have expected from CT.
Yeah.
CT, it's around, well, there are several studies in CT scans, 40 to 70%. So that is the main message, that in high-risk disease, PET-CT
improves the vision of nodes in these patients.
Yeah.
So this is a very interesting field, although the evidence are still scarce regarding that. I mean, we also have just after this talk discussing oligometastatic RNU and management of these patients that are N+, locally advanced. Where do you think the use of PET can improve the management of that patient? We already had a randomized trial on PET in bladder cancer, in muscle-invasive bladder cancer, who showed no real benefit and change of the therapy and the management at that time. So that's why PET is not still accepted abroad at a large scale, although it's still really used.
Yeah.
For UTUC, what do you think? Do you think you will use it as a primary imaging for every patient, only in high risk, after neoadjuvant chemo,
Yeah.
before? How do you think to manage it? And
Yeah.
maybe also maybe for the follow-up, because the renal function is not as good
Yeah.
as before.
Well, first of all, I think the most important kind of area to use it is the primary assessment.
Okay.
So the patients that come to the bladder cancer clinic, and they come with a CT scan, and then when we do a PET scan, and usually the time in between is very short, then you see more. Mm-hmm. So in the case that I have presented on UROONCO, there you can clearly see that there are nodes higher up. So in the around the clavicula, the Virchow nodes, mm-hmm. and they became positive. And now
they were not false positive.
No, and the patient that was initially thought to be kind of an induction setting, so chemotherapy and then, if response, surgery, now certainly converted to a patient that is palliative, so chemotherapy followed by avelumab.
Yeah, or EVP.
EVP.
Okay.
Yeah.
So if I get the take home is that there is a potential benefit for PET in that settings. I would say probably if you have a high-risk patient on the CT scan, then you perform a PET. So if you see T3, T2, T3, T4, then probably the PET has a real interest, especially if you decide of the first-line treatment, and probably EVP if it's positive, or chemo plus whatever you want as a first line.
Yeah.
And afterwards, would you also select some other patients that may have a benefit of PET during the systemic therapy, for example?
Well, we have for UTUC we have no data.
Okay.
However, for bladder cancer we have some data, mm-hmm. and actually the best way to use it is in the primary assessment. If you do, for example, a response evaluation for neoadjuvant chemotherapy, well, the PET scan is not better or different than CT. Mm-hmm. And so then CT is enough. For follow-up, well, usually then you do a PET scan if you are in doubt. Then you can, do an extra scan. But doing routine scans for response evaluation or in follow-up is probably not the way to go for PET.
Okay.
Yeah.
I think the messages are really clear. I thank you very much, Bas, for your time and for being with us at UROONCO on the UROONCO platform. It was a pleasure to have you. Thank you so much.
Okay, you're more than welcome.
Thank you.